Hey guys, how's it going? Today's topic is going to be about sepsis. We're going to talk about the new definitions of sepsis, how these patients will present, and we're going to go over what to look for on physical exam, what labs to order, what tests to order, and finally, how do we treat these patients? So let's jump right in today's topic and talk about sepsis. To understand sepsis, you must first understand that sepsis exists on a continuum of severity. It starts with bacteremia and infection and progresses to sepsis and septic shock. From there, it can lead into multiple organ dysfunction syndrome, also known as MODS, and even death. Now let's break down the spectrum of severity even further, starting with infection and bacteremia. Infection can be defined when tissue that is normally sterile gets invaded by organisms, resulting in infectious pathology. For example, when the normal sterile tissue of the bladder gets invaded by the enteric pathogen E. coli, an infection is born in the name of acute cystitis, whereas bacteremia is simply defined as the presence of bacteria in the blood. So why is this important? Because all patients with an infection or bacteremia technically have the potential to progress towards sepsis. But will every acute cystitis, cellulitis, pneumonia advance to sepsis? Of course not. And that's not what I'm trying to say. This is just a logical way to explain the progression towards sepsis in a stepwise fashion that is easy to learn and understand. Now, in the past, the SIRS criteria was used to help define sepsis, but that has fallen out of favor for many reasons which we will not get into today. Today, we are going to be talking about the new criteria for defining sepsis. The new criteria for sepsis was published in 2016 by the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. They came up with an assessment score called Q-SOFA, also known as Quick SOFA score, which is a modified version of the SOFA score to help easily identify septic patients at the bedside. The new definition of sepsis is now defined as an individual with a known or suspected source of infection and at least 2 out of 3 of the Q-SOFA criteria. You can remember the Q-SOFA criteria by the mnemonic BAT, B-A-T. B stands for a systolic blood pressure less than or equal to 100, A stands for altered mental status, and T stands for tachypnea with the respiratory rate greater than or equal to 22 breaths per minute. So once again, sepsis is defined as an individual with a known or suspected source of infection with 2 out of 3 Q-SOFA criteria. You can remember this by the mnemonic BAT, systolic blood pressure less than or equal to 100, altered mental status, and tachypnea, with the respiratory rate greater than or equal to 22 breaths per minute. Sepsis can also be defined by the SOFA criteria. In this definition, you once again have an individual with a known or suspected source of infection that have greater than or equal to 2 SOFA criteria. These scores, however, were meant to be calculated 24 hours after admission into the ICU and then every 48 hours after that to assess for organ dysfunction and to help predict mortality. So if you think about it, guys, to adequately use this scoring system as it was designed, you have to have a patient in the ED under your care for 24 hours. While I think this is a good tool to help assess for organ dysfunction, I think its usefulness in the ED is limited. So for those reasons, we're not going to get caught up in the full SOFA score today, but I will speak about it briefly here shortly when we talk about multiple organ dysfunction syndrome, also known as MODS. Continuing on the spectrum of sepsis, we now advance to septic shock. Septic shock can be defined in patients who fulfill the criteria for sepsis, who despite adequate fluid resuscitation, still have a lactate greater than 2 and require vasopressors to maintain a mean arterial pressure greater than or equal to 65. So unfortunately, they do not define how much fluid is adequate, but we will talk about that later in the treatment section. Briefly, I just want to mention that septic shock is a type of distributive shock, and it is caused by a poorly regulated distribution of blood flow. Even though the blood volume is normal, we still get profound hypotension because the vascular system vasodilates. So to recap, sepsis is defined on a continuum, beginning with infection and bacteremia, advancing to sepsis and septic shock, and ending with MODS and even death. Multiple organ dysfunction syndrome is on the severe end of the spectrum and refers to a patient with progressive organ dysfunction, so much so that the body's homeostasis cannot be maintained without intervention. More simply put, multiple organ dysfunction is a clinical syndrome that is characterized by progressive dysfunction in 2 or more organs. For example, let's take our septic patient in the ED. We get their labs back and we notice a creatinine of 4. And despite 3 liters of fluid, their systolic blood pressure still remains less than 90. And now they're requiring vasopressors. Now what you want to do is take a quick look at their old labs. Make sure that this isn't their normal renal function for them. You notice that they were in your ED last month and their kidney function at that time was normal. So now we have a septic patient with multiple dysfunctional organs. Both their kidneys and cardiovascular system are failing on their own and they're requiring intervention in the form of fluids and vasopressors. Now there's no universally accepted criteria to define individual organ dysfunction in MODS. However, there are specific scoring systems such as the SOFA criteria that can be used to diagnose MODS. The SOFA criteria looks at 6 organ systems to help the clinician identify MODS. You can remember this criteria by the mnemonic CPK BNP, where C stands for cardiovascular, P stands for pulmonary, K stands for kidneys, B stands for bilirubin, N stands for neurological, and P stands for platelets. So we're not going to get into the specific scoring system today because once again, these scores were meant to be calculated 24 hours after admission to the ICU and then every 48 hours after that to assess for organ dysfunction. Now that we've gotten all the definitions out of the way, let's talk about how these patients are going to present clinically. Before you go into the room, take a look at the triage note and review those vital signs. Does the patient have an elevated temperature? Take a look at the blood pressure. Are they hypotensive? Look at the respiratory rate. Is it elevated greater than 22 per minute? Look at the heart rate. Are they tachycardic? And finally, look at the oxygen saturation. Are they hypoxic? As with all patients, you want to start off taking a good history. Ask them when their symptoms started. Ask them about any alleviating or aggravating features. If they are in pain, have them describe the pain. Does the pain radiate or travel to another area of the body? And ask them about the severity of their pain so that later you can adequately assess if you are managing their pain properly. Now you want to take a good review of systems. Are they having a fever, headache, or stiff neck that could represent a meningitis as a cause for sepsis? Are they having a sore throat that could represent a peritonsillar abscess? Do they have a cough, shortness of breath, wheezing, increased sputum that could represent a pneumonia? Do they have any right upper quadrant abdominal pain that could represent acute cholecystitis? Are they having any dysuria, urgency, flank pain that could signify pyelonephritis as the cause? Do they have any focal joint pain or joint effusions that could represent a septic arthritis? Do they have any lumps or bumps that could signify an abscess or cellulitis as a source of infection? And finally, are they having any vaginal discharge, urethral discharge, pelvic pain that could represent a tubo-ovarian abscess or prostatic abscess? Furthermore, ask them about any recent admissions into the hospital. Make sure to take a good past medical history focusing on comorbidities that depress host defenses and cause them to be immunosuppressed, such as, are they a diabetic? Do they have AIDS? Do they have kidney or liver failure? What about asplenism? Also, make sure to get a detailed list of their medications. Are they taking any immunosuppressive medications, or do they just finish a round of chemotherapy? To be complete, make sure to ask them about their surgical history, allergies to medications, tobacco, and alcohol abuse. Next, you want to do a detailed physical exam. If the patient is having fever, headache, neck stiffness, and altered mental status, do a complete neurological exam and assess the neck for nuchal rigidity. Look in the mouth and around the mouth for any lesions that look herpetic, possibly indicating a viral meningitis. Look in the back of the throat and make sure there's no peritonsillar abscess if they're complaining of throat pain. Listen to their lungs for any abnormal lung sounds that could represent pneumonia. Listen and palpate their abdomen. Do they have a positive Murphy sign that could indicate acute cholecystitis? Do they have any rebound tenderness or guarding that could be possibly due to a perforated diverticulitis and a new abscess is forming? Do they have any hypoactive or hyperactive bowel sounds? Check for CVA tenderness. If they're complaining of flank pain, do they have any CVA tenderness secondary to pyelonephritis, or maybe they have an obstructed kidney stone? Do a full skin exam looking for abscesses or cellulitis, including the perirectal area. And check their joints. And by this, I don't just mean lifting up the blankets to look at their ankle. Remove the blanket, check all joints for any indication of infection that could represent a septic arthritis. And finally, if they're complaining of pelvic pain or vaginal discharge, go ahead and do the vaginal exam. Now let's talk about what labs to order. All patients should get a CBC with differential, CMP, lactic acid, blood cultures ×2, coagulation studies to include PT, PTT, arterial or venous blood gas, sputum cultures and chest x-ray if you're thinking pneumonia, and a urine analysis with culture. Laboratory signs are usually going to be nonspecific, and they might be due to the underlying cause of sepsis or secondary to tissue hypoperfusion or even organ dysfunction. So no one lab is going to adequately tell you that this patient is septic. So the CBC might come back and show either a high or low white blood cell count, with the white blood cell count greater than 12,000 or less than 4,000. You might even have a normal white blood cell count with greater than 10% immature forms. The CMP might show hyperglycemia, but in the absence of diabetes. Acute oliguria can be seen with a urine output of less than 0.5 milliliters per kilogram per hour for at least 2 hours, but you have to be giving the patient adequate fluid resuscitation. So in the typical 70 kilogram adult, they'd be putting out less than 35 milliliters per hour. You might see an increase in creatinine greater than 0.5. You might see an increase in your INR greater than 1.5, an increase in your PTT greater than 60 seconds. You might even see a thrombocytopenia with a platelet count less than 100,000, or maybe even an increased total bilirubin greater than 4. But if you're thinking meningitis as the cause, then none of those tests will be too helpful to aid in your diagnosis. You will need to get a non-contrast CT and a lumbar puncture. However, you're going to want to go ahead and get the non-contrast head CT before you do the lumbar puncture. The reason being is to exclude a mass lesion or increased intracranial pressure that could lead to cerebral herniation during the removal of large amounts of CSF during the lumbar puncture. However, studies are now showing that a screening CT is not necessary in the majority of patients and really only needs to be done before the LP in patients with 6 specific risk factors, which we will not get tied down in talking about today. Nevertheless, I still believe it to be common practice to get the CT scan before the LP. Just make sure that the CT scan does not cause you to significantly delay the start of antimicrobial therapy. If the patient is having abdominal pain, then you want to get a CT scan of the abdomen and pelvis with contrast to better see any abdominal abscesses. However, many of your patient's kidney function will not allow you to do the study with contrast, and if that is the case, go ahead and scan the patient without contrast. If the patient has a large joint effusion in their knee with warmth to palpation and just had a recent corticosteroid injection from their good old family doctor for arthritic knee pain, go ahead and do a joint aspiration. At this point, I'd go ahead and give your orthopedist a call and give him the option of doing the aspiration himself. If he does not feel the need to do it, go ahead and prep the patient for the procedure and send the fluid to the lab. Fluid should be sent for gram stain and culture, leukocyte count with differential, and assessment for crystals. Now, the moment you've all been waiting for. How do we treat these patients? Well, treatment starts at the bedside during the initial encounter with the patient, starting with the ABCs: airway, breathing, and circulation. Make sure the patient is protecting their airway and evaluate their work of breathing. Stabilize the respirations with supplemental oxygen. Establish IV access early. I typically like 2 large bore IVs, either an 18 or 20 in the AC, for my most sickest septic patients to start off. Now, the cornerstone of initial therapy is to restore perfusion and the early administration of antibiotics. I'll say that again. The cornerstone of initial therapy is to restore perfusion and the early administration of antibiotics. Rapid large volume infusions of 30 milliliters per kilogram normal saline or lactated ringers should be given. So in your average 70 kilogram adult, that's about 2.1 liters of fluid. After every 500 milliliters of fluid, you need to re-examine the patient. Listen to their lungs and make sure you don't hear crackles that could indicate pulmonary edema. Check to see if their blood pressure is increased and how do they look clinically. Is their mean arterial pressure now above 65? Do they have increased urine output? And how is their mentation, skin color, and hypoxia? Is it improving? If the patient is improving, continue giving fluid boluses until the blood pressure and tissue perfusion are acceptable, pulmonary edema occurs, or the fluid is no longer improving the perfusion. So in my typical practice, I give about 2 to 3 liters of fluid. While the patient is getting fluid, antibiotics should be started within 1 hour of presentation, and make sure to get your blood cultures before you start those antibiotics. Choosing the correct antibiotics can be complex. You should pick a regimen that covers a broad spectrum of antimicrobials, one that covers both gram-positive and gram-negative organisms in those individuals who you aren't quite sure what the source of their infection is. Vancomycin will provide you with good gram-positive coverage and against MRSA. If you don't think Pseudomonas is a likely pathogen, you can give cefepime and vancomycin. However, if you're concerned for Pseudomonas, give vancomycin, cefepime, and zosyn, also known as piperacillin tazobactam. The initial dose for vancomycin is based off the patient's weight. You will want to give a 15 to 20 milligrams per kilogram dose, so in your average 70 kilogram patient, that's a dose of 1,400 milligrams with a maximum dose of vancomycin of 2 grams. Cefepime is dosed at 2 grams IV, and zosyn is dosed at 4.5 grams IV. Although your ED most likely will only have 3.375 grams readily available, so it's probably better to go ahead with the lower dose instead of waiting for your pharmacy to make the larger dose for you. But what if we know the source of infection? Then we should target our therapy, right? For example, let's say we have a patient, they have a 12 millimeter obstructing kidney stone with pyelonephritis who has become septic. Vancomycin and zosyn would not give us the best urinary coverage, so as long as MRSA is not a concern, you could probably just treat with 2 grams cefepime IV alone. Now let's talk about the patient who, despite adequate fluid resuscitation with 2 to 3 liters of normal saline or lactated ringers and appropriate antimicrobial therapy, continues to have persistent hypotension with a mean arterial pressure of less than 65. In these patients, I commonly approach my attending physician and bring them up to speed with my patient. I tell them I have a very sick septic patient who, despite 2 to 3 liters of fluid and antimicrobials, continues to have persistent hypotension. I ask them if they can place a central line for me and start getting the kit together for my attending and speaking with the patient and their family to make sure we respect their wishes. For example, before you start placing central lines on a 90-year-old with dementia, multiple comorbidities, already on hospice, and is a DNR, make sure this is what the patient and the family would want. Once you have your central line in, you're going to want to start Norepinephrine, also known as Levophed, as your first-line agent in septic shock. Levophed acts on both alpha and beta-1 receptors to induce potent vasoconstriction and a modest increase in cardiac squeeze. The dose is 2 to 4 micrograms per minute with a theoretical limit of 20 micrograms per minute. Now, there is literature to support higher doses at 30 micrograms per minute, 70 micrograms per minute, and I have even seen literature to support doses as high as 100 micrograms per minute. I think the best way to approach this is to keep titrating up the dose as long as they are responding to about 20 to 30 micrograms per minute, and keep in mind you will reach a point of diminishing returns. But let's say you have a patient whose Levophed is titrated up to 30 micrograms per minute, yet they still have a mean arterial pressure less than 65. Well, this patient now needs another vasopressor. Unfortunately, guys, there's little data to support the best second-line agents in these patients. But I think a reasonable approach is if the patient is not tachycardic on norepinephrine, you could add epinephrine. Epinephrine is dosed at 1 to 10 micrograms per minute. If the patient is tachycardic on norepinephrine, then you could add vasopressin. For example, You have a patient who is tachycardic with a heart rate of 115 beats per minute. Adding epinephrine would increase the heart rate even further, worsening your tachycardia and possibly incite further decompensation. So since vasopressin completely lacks beta-adrenergic effects, it would be the better option in those patients who are tachycardic on Levophed. The dose for vasopressin is 0.03 units per minute, and this is not titrated. Now, after you've started your drips, you want to go back to the patient and continue to re-examine them. Listen to their lungs again, making sure you don't hear crackles that could indicate pulmonary edema. Check on their blood pressure, making sure it's staying above a mean arterial pressure of 65. How do they look clinically? Have their respirations improved, or are they tiring out and possibly need to be intubated? Has their urine output increased? Is their mentation, skin color, or hypoxia improving? So that's sepsis. Quickly, let's review rapid fire the main points we've talked about today. Sepsis exists on a continuum of severity. It starts with bacteremia and infection and progresses to sepsis and septic shock. From there, it can lead to multiple organ dysfunction syndrome and death. The new definition of sepsis is now defined as an individual with a known or suspected source of infection and at least 2 out of 3 of the Q-SOFA criteria. You can remember the Q-SOFA criteria by the mnemonic BAT. B stands for a systolic blood pressure less than or equal to 100. A stands for altered mental status. T stands for tachypnea with the respiratory rate greater than or equal to 22 breaths per minute. Septic shock can be defined in patients who fulfill the criteria for sepsis, who despite adequate fluid resuscitation still have a lactate greater than 2 and require vasopressors to maintain a mean arterial pressure greater than or equal to 65. Multiple organ dysfunction is a clinical syndrome that is characterized by progressive dysfunction in 2 or more organs. Before you go into the room, take a look at the triage note and review the vital signs. As with all patients, make sure to take a good history and perform a good physical exam. All patients should get a CBC with differential, CMP, lactic acid, blood cultures ×2, coagulation studies to include PT, PTT, arterial or venous blood gas, sputum cultures and a chest x-ray if you're thinking pneumonia, and a urine analysis with culture. Treatment starts at the bedside during your initial encounter with the patient, starting with the ABCs: airway, breathing, circulation. Make sure to establish IV access early. And remember, the cornerstone of initial therapy is to restore perfusion and the early administration of antibiotics. Rapid large volume infusions of 30 milliliters per kilogram normal saline or lactated ringers should be given. So on your average 70 kilogram adult, that's 2.1 liters of fluid. Remember to reassess your patient before and after every 500 milliliters of fluid. While the patient is getting fluid, antibiotics should be started within 1 hour of presentation. And make sure to get your blood cultures before you start those antibiotics. Pick a regimen that covers a broad spectrum of antimicrobials, one that covers both gram-positive and gram-negative organisms in those individuals who aren't quite sure what the source of their infection is. Vancomycin will provide you good coverage against gram-positive and against MRSA. If you don't think Pseudomonas is likely, you can give cefepime and vancomycin. However, if you are concerned for Pseudomonas, give vancomycin, cefepime, and Zosyn, also known as piperacillin tazobactam. If we know the source of infection, then target your antimicrobial therapy. If you have a patient who, despite adequate fluid resuscitation with 2 to 3 liters of normal saline or lactated ringers and has had appropriate antimicrobial therapy, yet they continue to have persistent hypotension with a mean arterial pressure of less than 65, put in your central line and give vasopressors. First-line agent in septic shock is norepinephrine. The dose is 2 to 4 micrograms per minute. Keep titrating up the dose as long as they are responding to about 20 to 30 micrograms per minute, and keep in mind you will reach a point of diminishing returns. If the patient needs another vasopressor, start either epinephrine or vasopressin. Now you want to go back to the patient and continue to re-examine them. Well, this completes the episode on sepsis. I hope that you guys found this helpful, and I appreciate any feedback that you guys might have on how to make this podcast better. If you have any questions or comments, please email me at gray@physicianassistantboards.com. Until next time, thanks.